Good afternoon, everyone. Welcome to today's joint webinar in collaboration with KNH, the University of Nairobi, and the Society for Quality Healthcare in Kenya. Today, we have the privilege of having a conversation within our series on quality, but now exploring the role of the private sector. And so today, again, we have able and distinguished representation from both the private healthcare providers and the private healthcare insurers under the umbrella of the Association of Kenya Insurers. For the private healthcare providers, we are privileged to have Dr. Brian Lishenga, who is the founding chairman of the Rural Private Hospitals Association of Kenya, a medical doctor, family physician, and physiologist of repute, as it were. For the healthcare insurance, private healthcare insurance team, we have able representation by Dr. Elijah Matolo, who is a medical practice manager, a health economist, and a medical doctor. He's also a member of the medical advisory committee for the Association of Kenya Insurers. And so it's a privilege for us to have them shepherd us through this conversation today on the role of the private sector. The reality is that Kenya within this region stands out as one that has a very robust private sector within the healthcare industry. The reality, again, is that upwards of 40% and more of our outpatient care and inpatient care is sought in private sector within our country. That's according to the MOH data, that's the Kenya Household Health Expenditure and Utilization Survey, most recently done and published in 2018-2019. Those numbers definitely have gone up, and that just serves to emphasize the fact that the private sector plays a very significant role within our healthcare space in this country. And by that, then, they have a very critical role to play as far as healthcare quality is concerned. I'll be moderating the session today. I'm Dr. Mike Mulongo, a medical doctor and a health financing specialist, and also representing the Society for Quality Healthcare in Kenya. Without further ado, it would be nice for us to begin the conversation from the provider side, listening to what the private sector hospitals are doing as far as healthcare quality is concerned, and what other concerns do they have? What challenges do they face as far as enforcing quality or implementing quality is concerned? So with that, I'll welcome Dr. Brian Lishenga to begin the conversation. Brian, over to you. Thank you.
Thank you so much, Mike. And good afternoon, everybody who is on the call. Thank you, Mike, for the introduction. Just for those who might have missed that introduction, my name is Brian Lishenga. I am a medical doctor, a family physician by training. I teach medical physiology for Egerton University. And I also have the privilege of being the current chairman for the Rural Private Hospital Association of Kenya. So thank you so much for the organizers for allowing us to share our perspectives. I have only 7 slides, so you can be sure my presentation will be very focused and short. So I'll proceed to share my screen. So I guess a great place to start, given that background, Daktari, is just a little bit about what the association that I represent stands for. As I said, I'm the chairman, the national chairman for the Rural Private Hospital Association of Kenya. This Association was founded in 2019, so we have been in existence for just over 4 years now, with an initial membership of 12 healthcare facilities that are privately owned and that were providing care in what you'd call rural settings. So that was the initial membership that came together, the team that came together to form this association. The motive around this formation was to bring to the table the voices of healthcare providers who work in rural communities. And subsequently, we expanded that a little bit because we came to find out that there is a lot of health inequity and the same challenges that the ordinary citizen faces with access to quality healthcare in rural Kenya, or also happening in urban settings. So we expanded our definition so that we now also have within our membership a very strong representation from private health facilities that are working at what you would call the bottom of the pyramid, or the medically underserved or healthcare provider shortage areas within our towns, within our cities. For instance, you will find a strong presence of the association in Nairobi, in Kisumu, in Mombasa, but mostly these are providers that are working with patients at what you call the bottom of the pyramid, where you have the usual access problems. You don't have access to physicians on time, or to medical specialties, or to certain services. So indeed, our definition as an association has expanded so that now we are an association for providers working in medically underserved areas and healthcare provider shortage areas. So that is what the Rural Private Hospital Association is about. We have made a conscious decision to maintain the name as it is, because remember that 75% of Kenya's population, as per the last census, is still rural. We do have a very large number of Kenyans who are moving and becoming urban dwellers. But even within those urban areas, as I mentioned, we have still challenges. So the association has also evolved because of the way our healthcare system is structured. A lot of people who seek healthcare today are either making payments for healthcare out of pocket, and that's the vast majority of Kenyans. I believe somewhere close to 80% of Kenyans don't have any form of medical insurance. And the about 20% or so who have a medical insurance are largely covered by the current National Hospital Insurance Fund. And within our network, largely our members provide what we call comprehensive care. In fact, the other name for the association is the Comprehensive Care Society. That is our tag. So you find that for the vast majority of our private facilities in our network, patients walk in and walk out without having to pay an extra fee. That is the kind of model that they operate, where the patient has an NHIF card. It's simply a walk-in, walk-out process. So therefore, these providers have unique challenges. Today, we are present in 44 counties, and we have a membership of over 350 private healthcare facilities, from CAF level 2 all the way to CAF level 5 within the association. And what are the key roles that we do as an association? Mainly 4 areas. We are very active in advocacy, especially in the legislative advocacy, regulatory advocacy, and even commercial advocacy. As you can imagine, this is a very important area, especially with the kind of reforms that the healthcare system is going through right now, where you have, the new bills which are coming in to reform how we run healthcare. We have been making sure that the voices of these providers in mashinani areas or in urban underserved areas are heard, so that the eventual structure of the health system can really deliver for the Kenyan people. So in that regard, we are very active in influencing policy, and we have very good collaborations with the Ministry of Health and with other stakeholders within the healthcare system. The other thing that we do strive for is to capitalize on economies of scale. So eventually it becomes very clear that part of the challenge in delivering quality healthcare is the cost of care itself. And when the cost of care becomes prohibitive, the market gets flooded with what you call low quality products. And one of the ways to go around this is to come together as the providers and find out, can we procure better? Can we procure more safely? And can we assure that products can arrive at healthcare facilities, quality products can arrive at healthcare facilities at very competitive market rates? And one of the ways to do that is to take advantage of economies of scale. So in that regard, we've come together and have established a drug agency called the RUFA Drug Agency, which is pioneering the first private sector group purchasing organization. I'm sure you guys are familiar with other group purchasing organizations. The public sector has KEMSA, the faith-based organizations have MEDS, and therefore what we are doing with the RUFA Drug Agency is the first private sector GPO that will intends to achieve that same kind of private sector uniformity that MEDS and KEMSA bring to the table. And we are also working on some quality of care initiatives that I will get into in detail in a minute. So on my third slide, what are some of the quality initiatives that we as an association are driving for our members? So we have collaborations that are geared towards improved clinical care. For instance, I mentioned on this slide that we have a collaboration with a company known as Medixus. So Medixus is a digital transformation company that provides a CPD accredited learning management platform for clinicians. And we managed to negotiate a very interesting package with them that lets our clinicians enjoy access to top quality clinical content within our network for a year for just about, I think it's about 120 shillings a month for any clinician working in a hospital within our network. This arrangement also has what we call the clinical handover tool. The clinical handover tool is meant to make sure that there's continuity in patient care. So we are looking at a situation where you have been on call as a clinician and you're about to log off, but when you're going away, somebody else is coming to take over the shift from you. Usually that changeover in shift, if it is not managed well, leads to compromising in the quality of care patients get. And through our collaboration with Medixus, we are now going to have a clinical handover tool available in our network, where a clinician who is logging off from a shift or logging into a shift has an access to an online sort of like chat, where everything that, say you wanted after you've gone, some patient kidney function needs to be done, you post that on that platform, and the clinician who comes next is immediately tagged on that, and they get a reminder, patient X in ward so-and-so needs to have a kidney function test done, or the X-ray results came through and we've reviewed and seen this. So these are some of the things that we are able to do through the association to improve care, quality of care within our network. The portal that we have with Medixus also has a clinical trials arm, which we hope to soon launch, so that we can bring the private sector to be more actively involved, especially in the communities where our association is active in clinical trials. We have collaborations for improving administrative skills and knowledge within our network. One of them that we have is a collaboration with an organization known as TUMIM. So TUMIM is a partnership where we, business owners and administrative staff, can access administrative and leadership training. So we are talking about, training on things like procurement, financial management, leading of teams, things that make a difference in management of your human resources, management of your inventory, etc. So we have this kind of collaboration, and we are cascading it through our network so that we can build capacity of our business leaders to make the kind of decisions that make the hospitals efficient run. Another collaboration that we are doing as a quality initiative is something to do with improved safety of patient data. And here we have a collaboration with a company known as Southend. Southend is one of those entities registered by the Office of the Data Protection Commissioner to conduct training for what we call data holders or people who handle data handlers to provide training and certification. So with this partnership, we are giving our members access to data best practices. And eventually, through these partnerships, we expect that all the hospitals within our network will be compliant with the Office of the Data Protection Commissioner. So these are some of just a few of the initiatives that we are doing as an association. Make sure that the private sector is mainstream in terms of quality. On my next slide, just want to focus on one aspect, that is the quality of health products and technologies. As I mentioned, this is a key area we have an interest in. We have an industry-wide collaboration with the manufacturers and distributors of health products and technologies. And through this collaboration, we are able to conduct, we started this 2 years ago. So we are able to conduct due diligence on manufacturers and distributors that we recommend to our members through our partnership program. So we have, pharmaceutical manufacturers, distributors of medical equipment who sign partnership agreements or get into partnership program with us. And through that partnership program, we are able to conduct due diligence. So for example, we look at whether your medical equipment is certified, whether you have registered correctly within the country, whether you have documentations to show that you follow the international standards for those equipment before we recommend any of those equipment or pharmaceutical products to our members of our network. And this is something that we intend to take to the next level through the group purchasing organization that I mentioned earlier, that is the RUFA Drug Agency. So our vision is to eventually have a fully fledged quality department within that drug agency that can vet manufacturers and distributors of health products and technologies, and possibly down the road have established a quality lab and equipment calibration system. So what I'm trying to show with this slide is that the possibilities around private sector are increased when the private sector works together, when facilities decide that some things are better accomplished together than as individual facilities on our own. So another area where we are really focused on is data. So one of the projects that we are running that is very important for quality is a project we call the RufaSoft Unified HMIS. So our major objective here is to ensure 100% digital transition within the RUFA network. So one of the problems you will find out with our small clinics, our level 2 facilities, level 3 facilities, and even larger facilities, is that a lot of the data is still being, patient data entered, recorded manually, even financial data, your books of accounts, your inventories, all these things are still being done manually in a lot of places, or at most, if somebody is doing this on an Excel sheet or using using an Excel for finances, but having hard copy files for patient records. So the problem with this is not only the issue of patient data, but even continuity of care becomes a challenge. And we notice this problem across the entire membership of our associations. What we have done is we initiated, with the support of some partners, a program to build a unified hospital management information system that is going to be freely available to all members within our network. So we want 100% transition, digital transition, so that all the records, all the patient data is available online. It is safe and secure. And one of the things we intend to achieve here is we want standardized nomenclature across the network. So if you're using ICD-11, which is what we are pushing for, we want every facility across our network to be using that for disease codes, and we want them to have the same drugs nomenclature, the same diagnosis nomenclature, and then one of the other things we are doing is working very closely with the digital transformation program that the Ministry of Health is currently running, so that in our entire RufaSoft architecture is fully aligned with the digital transformation program that is going on in the Ministry of Health. And eventually what we hope, and we know this is in line with the MOH, what they're trying to do is swappability of patient records. And so we are doing our part on this end as well. So I'll mention some of the challenges that are there on this quality journey within the private sector. One big challenge is the issue of fragmentation. So private facilities are generally pulling in many different directions when it comes to the quality journey. So making it very difficult to impose a single standard. What do I mean by this? So you find, each hospital is making independent decisions on how they're going to handle quality, how they are going to handle standards of care, how they are going to manage inventory, how they are going to manage HR. We have a very fragmented private healthcare landscape. And one of the things we are trying to achieve as an association is to unify these landscapes that we have. We are progressively and over time moving towards a single standard for the private healthcare system. The other problem we have is information asymmetry. What I mean by information asymmetry is due to the fragmentation, the free flow of knowledge on best practices is impeded. So you find that one healthcare facility is doing extremely well. They have JCI, they have, they are maybe on, their lab is Hookers accredited, they have taken the self-care journey, whichever system. And part of the reason why I'm bringing this, or some of them are very good at KQMH, part of the reason why I'm mentioning all this is to show you how diverse it is. Nobody is taking up a single standard or moving in a particular way. But you have some hospitals that have taken the journey so far ahead, and they have so much knowledge. But you have a lot of other healthcare providers who have no clue at all. So you have this huge gap in knowledge that needs to be bridged. And in our view, this is bridged by bringing everybody to the table so that they can talk to each other and learn from each other. The other problem that we have experienced as private sector is what I would call, and it's the slide shows it there, the black sheep status. So we have been struggling with a narrative for a very long time that the private sector is profiteering. Therefore they have no morals. They are amoral. Therefore, you can never expect any quality there, and they're just out there to make money. And the problem with this narrative is it ignores the fact that Mike mentioned earlier that in some parts of the country, close to 60% of the healthcare is provided by private health sector, and we do not have in the near future a situation where there will be no private sector in Kenya. In fact, it is likely that the private sector will continue growing stronger. So we do need to have a situation where the labels are toned down. We need to move away from the black sheep status where private sector is out to make money. In fact, I would dare say that the profit motive of the private sector is a key ingredient to one of the domains of quality, which is effectiveness. Effectiveness and efficiency, those two domains. You cannot talk of quality without talking about efficiency, which is the resource utilization. So are you using resources as prudently as possible? And are you that is efficiency, and are you achieving the intended outcomes that you set out to achieve? Patients going home, if it's an appendectomy, you want no issues. By day 3, the patient goes home. So the private sector tends, because of the profit motive, tends to handle these two domains pretty well. They tend to be more efficient, they tend to be more effective on their outcomes. And so we do need to move away from the labels. And these labels, unfortunately, have constrained efforts to build up quality in the private sector. So you find that many donor-funded quality initiatives, which are channeled through the Ministry of Health, do not, find a way into the private sector because of the labels. And we can address this and take the journey together. We have problems around financing mechanisms. I've mentioned some of the quality standards that are available in the healthcare market, such as self-care, Hookers, JCI, etc. These are very expensive. The hospitals which have taken this journey have invested massive amounts of money to get this kind of accreditation. And since private hospitals are privately funded, and most of them are either micro, small, or medium-sized enterprises, finances are usually on a very tight leash. And therefore, what we do need is to find a way to address the financial constraints around taking a quality journey. So those are some of the challenges that we are facing within the private sector. I think that there are ways to address some of these problems. So for instance, we can address the problem of fragmentation. Elimination of the fragmented private sector is very important. And this we can do by pushing quality initiatives through hospital associations. So RUFA is one of those associations. We also have the Kenya Association of Private Hospitals, our partner association. And we have the Kenya Healthcare Federation as well. I think that if quality initiatives are driven from that kind of bird's eye view, you're coming in through either RUFA or through Kenya Association of Private Hospitals or through Kenya Healthcare Federation, much easier for us to start handling the problem of fragmentation. And I'm happy that the associations are getting stronger. They are getting more better coordinated. They are coming to a place where they are getting professionally driven. So if we work through the associations, we'll be able to eliminate this issue of fragmentation. And one of the things I have to say here is to encourage healthcare entrepreneurs who may be on this call, please join an association. Don't take the healthcare journey alone. You can never know everything. Within the associations, you will be able to get a lot of knowledge. You will be able to share from your peers and be able to make this journey much more easy. Then there's the issue of financing mechanisms. And I think we need to set up financial tools, instruments to allow hospitals that want to take the quality journey to arrive easily. I have not seen any of the financial players who are financing the healthcare system. They are giving out loans for working capital. They are giving out loans for buying equipment. I am yet to see a product around a hospital that wants to improve how it does things. A hospital that wants to say invest in a new HMIS, a hospital that wants to invest in how to invest in training for its staff. So we don't have financing around this quality journey, and we need to see some products in the market for that. I think that there is room for in-house initiatives. What I mean by this is back to the point about hospitals being members of networks. If we have strong hospital networks working through associations, we can think of building capacity at the association or federation level, where they themselves have internal capacity to audit their members, to take their members on the quality journey. And this will end up being very cost effective. It will be easier to adopt. You will have a single standard across board. So these are some of my initial thoughts about where we are at the private sector. And as I promised, my presentation will be very short. I have come to the end. Thank you, Mike.
Thank you very much, Brian, for walking us through the perspective of the private hospitals, particularly from the lens of the small and medium-sized private facilities, which in essence are a bulk of the providers across the country. You have highlighted significantly so how you are leveraging on technology in service delivery, in data management, in coordination of care. You have also highlighted the initiatives you're doing towards capacity development for both administrative capacity and care for the healthcare workers, and significantly so around data management. I see there are quite a number of questions that touch on some of this, and I will begin with one from Dave, who says that, when he was in medical school, there were a few students, both for medicine and pharmacy, but today there are so many chemists for every hospital. And his main concern is how do we help police the proliferation of quacks? Essentially, how do we ensure quality at the grassroots level, particularly now with the mushrooming of many private facilities? So there's a regulatory component to it. There's a training and capacity component to it, but it would be nice to hear from Rufa because you are the people on the ground. So what efforts are you putting in place to stem this challenge of quacks, offering care, not just pharmaceutical services, but also just care in essence? To you, Brian, you can respond to that.
Mike, thank you, and thanks, Dev, for that question. I will start by saying what we are doing as an association. So one of the things that we are very, very keen on is the onboarding process of new members. We have a very elaborate KYC process, that is know your customer kind of process. So we take on members who our criteria is very, it's open. It is actually on our website. You have to be a validly registered healthcare provider or healthcare facility. We have to see your up-to-date licenses. We have to see that you are registered with the relevant regulatory bodies and that you maintain those licenses. That is critical for us. So we try to make sure that at our level as an association, it is not it's a very much an open door for you to join, but we allow, there's a criteria for joining. We allow only those who are regulated to come in. So I can tell you that is one thing we do. The other thing that we have been very keen on is developing an internal anti-fraud policy, which is also available on, I think should be available on our website as well. So this is a code of conduct kind of document that we circulate to all our members. It's part of what we call the startup package. When you join the association, we share with you documents, including a code of conduct and an anti-fraud policy that you subscribe to by virtue of being a member of the association. So it is a sort of peer review mechanism internally. And even in the past, we have gone ahead and taken very strong decisions against providers within our network who have been implicated, let's say, in fraudulent activities, or they have been implicated in providing, in providing very unsafe care to patients. We do not shy away from taking action against those ones. So that is on the side of what we do as an association. And I think this is the way to go. Part of this is peer review. And the way to do it, peer review, is to have providers check each other. And you can actually become a pariah hospital, a pariah diagnostic center if it comes to the public knowledge and it comes to the knowledge of the association that you are engaged in those kind of activities. On the other hand, we think, and we have talked about this with our friends in the ministry and in the parastatals like the KMPDC, etc. We think that Kenya requires a unified quality body. The idea being that we have too many of these regulatory bodies acting disparately. So what do I mean? KMPDC, comes and checks. Nursing Council comes and checks. The laboratory comes and checks, and you require all these sort of regulatory checks for a health facility to be operational, and they don't talk to each other. We had hoped that through KHPOA, this would be sort of unified, but for some reason, KHPOA has not been properly funded. It has not been properly strengthened. So we do need to see a situation where we unify standards under a single framework. I mean, you have a department in the Ministry of Health that comes up with KQMH. KQMH, that department doesn't talk to NHIF. NHIF doesn't talk to KMPDC. KMPDC doesn't talk to the laboratory. All this needs to be sorted out if we are going to be able to handle the issues around quality of care.
Thank you, Brian, for highlighting the role of regulation. Regulation at peer level, so that is self-regulation, and you're doing that. The initiatives you're putting in place as RUFA, and also for highlighting the need for streamlined or a non-fragmented national regulatory environment through the ministry, through the Kenya Medical and Practitioners and Dentists Council, the KHPOA, as it provides oversight over the healthcare practitioners within the country, and all the allied entities. So streamlining regulation at national, subnational, and also at peer level. So thank you for that. I think it's also worth highlighting the role of the public in also driving quality, particularly when there are issues or identified quirks within the population. The other bit that I think worth exploring with you a bit more is the aspect of standards of care, and this is also a conversation that we will explore with the payers, particularly the insurers. So, to what extent, how does the journey of standardization of care look like from the private sector perspective? Because the patient is the same. Management of malaria, ideally, or malaria just as a reference illness, as it were, is well known. There's evidence around it. How can that be standardized across board so that then there is some element of predictability of the management that one should receive? We've seen this in other jurisdictions. For instance, within the UK, there's a nice guidelines for care. So how can that be? How can we domesticate and contextualize standards of care within the healthcare space in Kenya? Brian.
Thanks, Mike. I would just pick up from the point you mentioned about other jurisdictions. So, one thing you'll notice about jurisdictions that have been successful in having a fixed standard for, and a standard that is followed by providers, is that there are incentives attached to following those standards. Let me give you an example. We take Canada, for example, the healthcare system. They deliberately incentivize healthcare providers to follow standards for, say, helping patients who want to quit smoking cigarettes, standards for facilities that implement the standards for diabetes management, for instance, standards for taking care of renal patients. And how they do this is they have linked the standards to the provider management platform. So let me give you an example. For instance, we are using an NHIF platform to see patients when they come in. You log in the patients you have seen. What we would do in Kenya here would be to check, first of all, to incorporate the standard in any of our HMIS systems and to make them communicate to each other. And then we can check every single year or periodically how many hospitals are treating patients as per standard. So for instance, you have a diabetic patient, you know that they must have, if they are not properly controlled, they must have a glycated hemoglobin every 3 months until the HbA1c falls to the level. And then after that, subsequently, they have a follow-up HbA1c every 6 months. Now, these are things which are very easy to establish if you are using a unified platform in which the standards are integrated, because you will be able to see, yes, this patient visited hospital X on this day, they were diagnosed, they are diabetic on follow-up, there was a HbA1c done every 3 months because they were not under control, and then they subsequently got under control, and they have one being done every 6 months. And you can do the same for patients with heart failure, patients who are on follow-up for high blood pressure or renal disease or whatever, any of these chronic diseases, and patients who are being managed for substance addiction. So you have all these standards that can be incorporated in the digital systems that we have right now. And you can be able to log in and find out which providers are actually implementing the standard. But what they do in Canada, for example, they go even further than that. Once they find out that you have treated X number of patients, or let's say diabetic patients, they have a threshold as per standard over the last 1 year. At the end of the year, that facility gets paid a bonus just for maintaining the standards. So you can imagine how many facilities are incentivized to keep doing the per standard. And on the flip side also, they have penalties for facilities that do manage patients out of standard. So this is how we need to be serious about this. Incentivize facilities to maintain, to achieve standards and keep them for patient care, and also provide feedback for those facilities which don't do. It means we have to get very good at data collection. We have to get very serious at how we provide care, and we have to make the standards available at the touch of a fingertip. They should not be optional. They should be part of the system as we do it. So that would be my first take on that. And we gave these proposals to the National Hospital Insurance Fund when they published their regulations for 2023. They were publishing them last year. We told them, find a way to incentivize facilities that manage patients per protocol. And in Kenya, we have great standards for, let's say, managing diabetes or asthma. Why can't we incorporate those standards into the healthcare management platforms and then reward the hospitals that actually do achieve those targets? In terms of the second question was how does the quality journey look like in a private setting? As I mentioned, fragmentation is our key problem. So everybody is taking their own journey, and we have to make an effort to unify this. So if you are to ask a hospital somewhere, they will tell you we follow KQMH. Another one says we went through the safe care journey. Where are you? Nobody is following up on that. Another one will tell you, oh, our lab, is HOOKAS accredited. Another one, following the SANAS standards. So we have all these fragmentation and also information asymmetry. So hospitals, there are some hospitals that are doing really great job at standards. They're following their own processes, but a lot of providers do not even know where to start. So we have this kind of fragmentation. So they're taking independent journeys. And as I mentioned, also you have the problem of cost. All these quality journeys that hospitals need to take cost money. And a lot of these providers are micro, small to medium enterprises. So that I'll tell you is where we are at. And in that problem that I have defined lies the opportunity for us to transform this.
Thank you very much, Brian. I know because of time, we may not address all the questions, but I know there are questions that have been typed and touch on how people can engage with RUFA, how they can contact, how they can partner, and so on and so forth. So I think you can feel free to respond to those in text. And your response to this in terms of the incentives for quality would be a better segue for us into the next conversation on the role and the experience of the private payers, the insurers, as they work through enforcing or implementing quality in health. With that, I'll want to welcome Dr. Matolo to give his presentation on behalf of the private sector insurers under the banner of the Association of Kenya Insurers. Over to you, Dr. Matolo.
Hello, good afternoon, everyone. So thanks a lot for this invitation, and thanks a lot, Dr. Mulongo and Dr. Lishenga for the earlier presentation. So I'm the medical practice manager at Old Mutual. Dr. Elijah Matolo, medical doctor and a health economist. and I also sit in the Medical Advisory Committee at the Association of Kenya Insurers. These are some perspectives around what private health insurers think about quality. And just for some perspective, the private health insurance industry has been growing quite significantly. Those are the premiums collected over the last 8 or so years. So last year, the industry collected about 55 billion in premium. In terms of profitability of the industry, it's actually been quite hazy.
Dr. Matolo, you are muted. Looks like he has dropped off, most likely a connection issue, but he should be joining. I think he just dropped off while he was giving us the context. I see he's back. Karibu Daktari, he was just giving us a context of the private sector insurance industry and the statistics as far as the premiums collected, that they have been increasing, but as far as profits, as it were, that has been an elusive unpredictable space. Feel free, Daktari, to project when you're ready. That the bulk of the years have been making losses, except for just 2 or 3 years where they've made quite some notable profits. It's also worth to note that the key drivers of those profits for those few years, you'll notice it's just a few companies, not all of them. So it would be nice to hear from their perspective. Over to you, Daktari.
Okay, I'm sorry. Can you see the slides now?
Yes, we can see them.
Okay, so I can continue.
Yeah, go ahead.
Okay, sorry about that. Yeah, so I was indicating the number of people with private health insurance. So Dr. Lishenga spoke about how few they are. So the actual number is just under 1.4 million. That means technically they pay a premium of about 40,000 or so. So that's important in terms of how much can actually be spent. So quality healthcare. Quality healthcare from the WHO, they stress that its quality is a key element of UHC, and poor quality care actually results in deaths anywhere between 5.7 to 8.4 million every year, and this represents about 15% of the number of deaths within the low and middle income countries. 60% of deaths in lower and middle income countries come from conditions and due to poor quality care. So the remainder are the ones that happen because patients probably did not have access to care. So you can see poor quality care is actually a big problem. Yeah, inadequate quality also imposes significant productivity losses to the countries, and this is estimated at almost 1.5 trillion USD each year. And it's not just within the low and middle income, even in high income countries, there is statistics around what poor quality care means. 1 in 10 patients being harmed while receiving hospital care. And it's estimated that high quality care will actually prevent up to 2.5 million deaths from cardiovascular diseases, 900,000 from TB, 1 million newborn deaths, and almost 150,000 maternal deaths every year. So patient safety, about 50% of harm is preventable, and hence why discussions around quality become very important. Estimating almost 50% of harm caused is actually due to medications. The other important bit is that patient harm actually reduces global economic growth, and there are much more in indirect costs. So I'm sure we've all seen the 6 domains around healthcare quality: safety, effectiveness, equity, patient-centered efficiency, and timeliness. I think a lot of this work came from the US. I think there are some 2 seminal reports, one from 1999 called To Err is Human, Building a Safer Health System. One of the key things I picked from that is that human beings in all lines of work make errors. So that includes even healthcare workers. And errors can be prevented by designing systems that make it hard for people to do the wrong thing and easy for people to do the right thing. So it's really a question around how our healthcare system is designed, and not about any of the individuals or the individual healthcare workers within the system. When you look at this other report about an agenda for crossing the quality chasm, where they're saying there's a big gap between what we know works, basically what we have as evidence, and what is done on the ground, which is practice. There's some key commitments that came from this report. This was in early 2001. And they were really asking people to commit. And by people here, talk about all the relevant stakeholders, including policymakers, purchasers, regulators, health professionals, healthcare trustees, management, and even patients. Yeah, so one of the commitments was committing to purpose for the healthcare system as a whole to be a shared agenda of 6 aims for improvement that can raise the quality of care. So that was the 6 quality domains that we saw earlier. There's also adopting a new set of principles to guide and the redesign of care processes. We've said it's not about the individual healthcare providers. There's also identifying a set of priority conditions upon which to focus initial efforts. So quality is quite diverse. So it's very important that you identify focus areas that you start with. And healthcare organizations should design and implement more effective organizational support processes to make change in the delivery of care. So when you're looking at the stakeholders, some of the key things that can result in, can bring improvement is looking at creating an infrastructure to support evidence-based practice. Yeah, so we must make sure everyone is actually adhering to what the evidence says. There's facilitating the use of information technology. So systems, data becomes very important. And I think we've seen that from RUFA. Aligning payment incentives. I think this cannot be overemphasized. People usually do what you pay them to do. So if you pay them to offer quality, they will actually do that. And preparing the workforce to better serve patients in a world of expanding knowledge and rapid change. So examples of poor quality care, I think poor quality care can come in every single part of the healthcare system, and can come from each and every one of the professionals. So from primary care, you have issues around inappropriate prescribing. In maternity care, you can have unsafe delivery practices, which might include, inappropriate use of instrumental delivery, or even unnecessary cesarean sections. When it comes to pharmacy, then multiple areas, including medication errors, ignoring drug interactions, counterfeits, limited access, and unregulated pharmacies. In the lab, there are also multiple areas where you can get poor quality coming in, inaccurate calibration of equipment, failure to follow protocols. The same can also apply from the imaging department. You can have patients being positioned incorrectly, resulting in poor images, using inaccurate protocols or even calibration of the equipment. So hospital care, I think the usual that we will see, so things like hospital-acquired infections, patient falls, pressure ulcers, nutritional challenges, and even in critical care. So you have ventilator-associated pneumonia, ventilator-associated lung injury, and bloodstream infections associated with central lines, and many more. I think there's literally poor quality can come in various areas. So the more interesting bit, so private health insurance. So when I showed the premium being collected, so we have about 20 private health insurers, and largely these are the challenges that we'll be facing when we try and advance quality healthcare. So the first one, of course, is the issue around cost. So it's very important that it's understood the private health insurers work with a finite amount of resources, which is the premiums collected from their policyholders. And the aim is to try as much as possible to provide all the care that is needed within the available resources. So balancing cost with the need to provide high quality care is usually a major challenge. So private health insurers will work with the service providers and looking for the providers who are able to offer high quality care then becomes very important. Managing these relationships and making sure that your hospital, doctors, and other healthcare professionals are maintaining quality can sometimes also be quite complex. There's a lot of data that would be required to assess the quality of care. Sometimes this data is not available or there's no proper way of collecting it. So if you're saying you have diabetic patients, from where we're seated, most of us are not able to tell how well patients are doing on a day-to-day basis. But you can tell if things have gone wrong because then you will have patients being hospitalized. There's a lot that needs to be done in terms of educating consumers, and that's educating them about what they are covered for, and also guiding them around, who are the providers offering high quality or cost-effective healthcare services. And sometimes it might also be the insurer might not have a very objective way of telling which providers are offering the high quality, cost-effective services. So then now that means also the consumers will not get assistance there. So when it comes to preventive care and management of chronic diseases, one challenge is how to encourage or incentivize your members to get preventive care. And, because this prevents complications and also is able to generate long-term savings and improve overall health outcomes. Technology is also another important part. Most hospitals right now will have a HMIS system, but how you get data being transferred from the hospital system to the insurance claim system sometimes becomes a challenge. So integration is not always straightforward. So fraud and abuse is there in all healthcare systems. And while insurers try to combat fraud and abuse, it's important that they also ensure that legitimate claims are processed and paid promptly. The other challenge is around how to actually measure and ensure quality. So the first part there is making sure you're able to define and measure the metrics that will define healthcare quality. So some of the areas where we feel private health insurers can help in driving quality, and these are some of the things that we are currently doing. Is promoting preventive care. So providing coverage for health screening and vaccination, and that is both vaccination both for children and for eligible adults. Designing programs that educate members about healthy lifestyles, diet, and exercise. The second one is around management of the provider network, making sure you're establishing a provider network that is based on quality metrics and encouraging your members to actually use that. A key challenge is the fact that sometimes not very clear who is offering quality, because this information is never shared publicly. Yeah, so most hospitals will keep their quality metrics largely, as part of their internal data. Yeah, providing easy access to transparent provider information. Sometimes this information is usually not provided. So even things like tracking outcome data, it's important that first of all you determine what outcomes of interest are you trying to define. Are we all clear about how they will be tracked? And then now making sure then that this information is actually made publicly available. And as a way of, first of all, just recognizing and appreciating those who are doing well and providing an incentive for those who may not be at that level. So earlier on, it was mentioned how value-based care would help in driving quality. And here you're talking about how you link provider payments to quality of care rather than the quantity of services. The current payment models, especially fee-for-service, they basically reward providers for offering more services. And that's typically what will happen. So you get a lot of lab tests, a lot of medications, while the ideal is that you actually paid for the quality of care that patients are offered, and they need to have an objective way of rewarding outcomes. The other one is facilitating communication among different healthcare providers so that there's a seamless patient care. Use of data analytics. So insurers have a lot of data, and if effort is put into it, you can actually identify patients who would otherwise be termed as high risk. A patient who's maybe has too many encounters with the health system might need more support in terms of the care that they are getting. And if there's more data maybe around their outcomes, including even intermediate outcomes, blood sugar and the like, then you can tell some patients might actually need better support, and that is in advance so that you can intervene. Implementing advanced analytics to detect fraud, to ensure that resources that are limited are used for the genuine healthcare needs. Telemedicine and digital health. So most insurers right now have taken up telemedicine, and it's a way to improve access to healthcare and also reduce the strain on physical healthcare facilities. And I know there are early attempts to see how to start integrating data from wearables into health insurance programs to encourage members to live healthy and to also allow for early intervention. So collaboration with healthcare providers. So the healthcare facilities are the ones providing the care to the members. So if there's a way to develop joint programs where set targets for patient outcomes, see how to reduce cost, and so that you can enhance the overall quality of care. There's importance in also supporting ongoing training and education for healthcare professionals to ensure that they keep updated with the latest advancements and best practices. There's transparency and accountability, two areas. So first of all, making sure that members understand what they are covered for. And the other one is making sure that there's an open channel to provide feedback, and that the feedback is used to improve services, including even services at the healthcare provider. So we said that the fee for service incentivizes overuse of services. So it becomes important to have utilization management programs to prevent unnecessary tests and procedures while encouraging evidence-based practices among providers. Ideally, this should be guided by evidence and by guidelines. So if the guidelines say this is what we should do, then ideally that is what all professionals should be expected to do, and what the insurer should be supporting. There is a very important part is patient engagement or member engagement. So a lot of the diseases, especially the non-communicable diseases, can be prevented with healthy lifestyle, and incentives should be provided to encourage members to live a healthy lifestyle and to actively engage in wellness programs, and making sure that insurance products are tailored to patients' individual health needs, and they get support too based on their individual circumstances. Last but not least, it's a question around advocacy. So insurers should spend a bit more time participating in discussions and advocating for policies that improve the overall healthcare system. So, and this is in making sure that there's adoption of evidence-based practices, and there's also increased funding for public health initiatives and research. So this is one such, there's an initiative called Choosing Wisely from the American Board of Internal Medicine, and they have all their professional associations providing guidelines around some of the things that should not be done. You can see this example from pathologists discouraging performing population-based screening for vitamin D deficiency, performing low-risk HPV testing, and avoiding routine preoperative testing for low-risk surgeries without a clinical indication. And the reason why this is important is because any intervention that the insurance pays for, there's an opportunity cost. There's something else somewhere down the line that is actually not being covered. So how then do we support the insurers to actually be paying for what works? I know Dr. Lishenga mentioned this. There is an initiative from Canada called Using Labs Wisely, and hospitals are invited to join this national consortium, which where they have committed to make measurable impact in reducing low-value lab testing. And it becomes, it's prestigious to actually be part of the initiative, and there are real perks to participating. So there's receiving national recognition. There's part of this goes into licensure and accreditation requirements. Yeah, so finally, I think this is a health technology assessment has a key role to play in also defining quality care. And the reason for this is because most times poor quality care might be provided because people have not really taken time to understand what the evidence says. And health technology assessment provides a framework where you determine the value of health technologies, whether it's a lab test, whether it's a surgical procedure, even a new process of how to manage patients within a ward or within the outpatient setting. So this would actually help to say that these interventions work, so let's continue doing them. These ones do not work, so we need to stop doing them. And the idea is making sure this process is quite transparent and accountable. Yeah, so in terms of take-home message, I think poor quality care is a global problem. Yeah, but as happens with most other health metrics, the low and middle incomes are actually disproportionately affected. Yeah, so the adoption of clinical practice guidelines and evidence-based practices is central to quality improvement. professional associations, and also by extension, hospital associations can and should lead the way in quality improvement. Need to look for a way to incentivize providers to implement continuous quality improvement initiatives. I think we've seen there's a significant cost involved, so we need to show the providers how they will actually get a return on their investment in quality improvement initiatives. Patient engagement is also crucial. We need to make sure patients understand what quality is, and this also helps in reducing harm. Implementing health technology assessment frameworks to determine the value of the healthcare services, so that we offer the services that do work and we stop offering those that don't. Poor quality care increases healthcare costs, and in turn, it also increases insurance premiums. And savings from continuous quality improvement initiatives can be reinvested into other priority health areas. So ideally, the money doesn't leave the system; it still comes back to support other areas. And finally, private health insurers are key stakeholders in continuous quality improvement. And we believe that we can work together with our the healthcare professionals, the associations, both specialist and hospital associations, to make our healthcare system deliver better quality care to all the patients and the population in general. Thank you.
Thank you very much, Dr. Matolo, for that insightful presentation on the role of the private sector and highlighting the context, the challenges, and some of the interventions that you recommend as the way forward. I'd like to pick up on a few before I open this to the plenary. And it's still on the standards of care and the guidelines, because you have mentioned what you pay for sort of drives the habits. If you pay for, if your mode of payment is fee for service, and you're paying for the number of services that are provided. So there's an incentive. There's something you're incentivizing among the providers. I'm curious to find out what you as insurers are doing to incentivize the use of standards of care and guidelines of care. Yes, just any quick thought on that?
Yes, so thanks a lot, Daktari. So as private health insurers, we are very aware to the fact that evidence-based practice would make things better for the system in general. A lot of the costs that we end up paying for actually go to poor quality care due to some of the challenges we've highlighted around awareness of what the evidence says, the perverse incentives that exist within the payment mechanisms that we use. So we have we constantly engage with our hospitals, the hospitals that we work with, and also professional associations, to see how we can improve the adoption and adherence to the available clinical practice guidelines. I think the challenge sometimes comes in, especially because we largely work with the private hospitals. There's always a feeling that some of the guidelines provided are or were meant for the public sector. So then now there's a feeling that they don't necessarily apply to the private healthcare setting. Yeah, but we think that there's room for us to, whether they need to be customized or adapted or just adopted as they are, they would come in and provide a significant benefit to the patients that we support. So yes, we would like to see a situation where all the healthcare providers are actually adhering by the treatment guidelines that are available. And then now it's for us to then see how then do we start also incentivizing those who are actually adhering to that. Thanks.
Thank you. Thank you very much, Matolo. I see there are quite a number of questions. I think Odor also asks a question that touches on payment design and the incentives, right and perverse, that arise from that. And I think his question is tagged on particularly capitation, where then the providers are perversely incentivized to cut, to reduce the services or cost cutting so that they are able to maximize returns also for themselves. So the question there is, so what is Aki doing in terms of trying to strike that balance between rent seeking and patient safety? As you respond to that, there's also a question on your thoughts on telemedicine and digital health for home-based managed patients. Any quick responses to that?
Yes, so I think, so with regards to capitation, so most private health insurers have not really used capitation because I think there are some unique nuances around how that system would work. Because most of the times you'll find our members might not necessarily understand what it means when they go to the service providers, because you also capitation would work ideally if you have a very strict adherence to the treatment guidelines, so that there is no risk of rationing of care. So on our side, we know that fee-for-service then is a complete extreme opposite of the capitation, where the risk now becomes patients getting more services or more care than they possibly required. So they get more medications, they get, there's more testing being done. So some of the things that we are doing is really looking at how then do we work with our partners to have a balance between what would be payable maybe per visit, and these things need to be discussed in advance. So you're talking about if you're talking about maybe management of an episode of acute tonsillitis, so then you need to see what goes into that episode of care and what is the expected cost. And only at that point in time can you say, then this one, the maximum we should pay is maybe 500 or 600 shillings or whatever other amount. So there's all of these discussions should not really start with the cost first, should first start with the quality side. So what are the services that actually need to be provided to get the patient better? Then now once you have identified, then that's then now where you can now go and start looking at what does it actually cost to provide that. So maybe with time we probably eventually graduate to capitation payments, and hopefully the capitation that has a bonus aspect where providers are then rewarded for providing or achieving the desired outcomes. Yeah, so in terms of telemedicine and digital health, all the private health insurers have embraced telemedicine in one form or another. We understand that there are real benefits for patients, especially the ones, either the ones who have minor acute ailments, and they don't necessarily need to go to a hospital setting. So they can get consult a doctor online and get their medications delivered to them. But it also comes in handy for patients with chronic conditions, so that also saving them the time it takes to go to see a specialist, and also the associated travel costs. So you can have some of the follow-up visits being physical, and some of them being virtual. So it's something that we have embraced fully, but the uptake has not been that well. So I think the providers offering telemedicine services also have a bit of work to do to make patients understand the value or the benefits they can get from that. Thanks.
Thank you very much. I notice we have less than 7 minutes, but there are a few questions that I see in the chat box that I think either Brian or yourself can address. There are some that are direct to you, Matolo. You can respond to them on chat. But I think this conversation on antimicrobial resistance has multiple facets to it. There's a provider facet to it. There is the patient facet to it. There's a regulatory facet to it. I'm curious to find out from now, Brian, any thoughts on that? And as you talk about that, Matolo, you can also prepare a response to that and also a response to the conversation on generic medications versus originator and their impact on antimicrobial resistance and their cost implications, as it were, within our context. But Brian can go ahead first.
Thanks, Mike. I see the question is on antimicrobial stewardship. Hospitals addressing giving high-end. Well, I would take let me give the other extreme. The other extreme is just tied to what Daktari was talking about, capitation model, the disincentives around it, or perverse incentivization. So when you see with the capitation model, what we have been experiencing in the hospitals is to provide minimum care. The incentive around it is because you have transferred the insurance risk to the hospital. So the hospital then is incentivized to provide minimum care. And what we have seen that has been extremely worrying is literally all patients are on, the same, for whatever condition, when you come, it is amoxicillin. Of course, you have to get worried about the antimicrobial resistance. So it can happen on both extremes, whether we are talking about what my colleague is talking about, high-end second-line drugs for simple diseases. The issue here is tied to incentives. When you design a system deliberately that doesn't pay providers to provide the minimum beneficial care, but pays them when they provide, the most sophisticated type of care. That is where the problem comes through. Or you have a system where providers are not fully rewarded. They then start cutting corners. So you will end up with these issues. We do need to design the system from the bottom up so that we don't end up in this kind of situation. And also the issue of using technology to follow up on such things. We now are in the age of data analytics. We can be able to leverage on data to see which hospitals or which providers are making this problem worse.
Thank you very much, Brian. Any quick comment, Matolo, before you both of you give your closing comments?
Yeah, so I think on the antimicrobial stewardship, my interaction with hospitals tends to focus more around the critical care settings or inpatient settings. But then now in the outpatient setting where most antibiotics are given, sometimes there's hardly sufficient oversight. So I think it's a question of how then do we make it cool to have an antimicrobial stewardship program that hospitals can say, yes, we have a robust program, share some of the findings so that it becomes a good thing for you to do. I think on the payment side, it's also a question of is there a way to pay the hospital more because they didn't give the antibiotic? as opposed to paying them because they actually gave an antibiotic that was ideally not necessary. So there is a bit of rethinking around how the payments for some of the acute episodes should be handled. Thanks.
Thank you very much, Brian, Dr. Matolo, for finding time to have this conversation. I notice time does not allow us to go further. I'll just give each of you half a minute to just have any closing comments in view of the conversation we've had. I'll start with Brian and then Dr. Matolo. Any closing comments, Dr. Lishenga? I think you're muted. Matolo, you could go ahead.
Yeah, so thanks a lot. I think this was a good conversation. I think from the private health insurer side, we want to reiterate that we believe that quality should come first before any discussions are around the cost. Some of the conflict that comes around is usually because there's that lack of understanding of what either of the parties want, and it's really imperative for the healthcare professionals to be the ones to determine what is quality care, or to provide guidance around that by having guidelines that are nationally representative, that can be used across all healthcare settings. Yeah, so that when we ask what do insurers cover, insurers should cover what has been defined within the national guidelines for whatever illness is there, and not probably subjective decisions at individual level. So I feel there is a room for us to work collaboratively, because at the end of the day, I think we all want the best for the patient. We can always agree on how best to achieve that. Thank you.
Thank you very much. I noticed there's quite a lot of comments around the CPD point. I know the KNH research team is taking charge of that, taking note of the comments, and they should address them, whether it's a link for the CPDs or the actual CPDs being dispatched. I think the KNH team will handle that. It's now 31 minutes past 3 o'clock, a minute past our closing time. We want to thank each one of you for finding time to join us during today's webinar. Thank you for the panelists for the presentations that they have ably taken time to take us through. We look forward to continuing this conversation on quality. And as you work in your respective offices and places of work, please remember to advance the cause of quality. Thank you very much. It's been a pleasure through the Society of Quality Healthcare. Have a pleasant afternoon. Thank you very much.